I'm Tom Cataldo. I am a colon and rectal surgeon here at the BI in Milton, and I also practice in town at the BI in town. Went to medical school at the University of Massachusetts in Worcester, which is my hometown. I did my residency there as well. And then I went off and did my fellowship in New Orleans at the Oxford Clinic, and then started practice. I started first in New Jersey, and then I was in Rhode Island, and here I am in the Boston area. I like to say, as a Massachusetts native, every morning my wife would wake up, kiss me and say, "Are we moving back to New England today?" And so I've been migrating north and east ever since until came back to roost here in Massachusetts. When I was first in practice, I used to do general surgery. I would do hernias and gallbladders and things like that, but now I've narrowed my focus to this. And the overwhelmingly great thing about colorectal surgery that compared to something like heart surgery is heart surgery surgeons just do hearts, and they do almost the same operation all the time. I can do great big belly operations. I can feel very good about curing cancer or taking out diverticulitis or ulcerative colitis, or I can do very delicate little operations like anorectal surgery, hemorrhoids, fissures, in people that aren't necessarily sick but have trouble holding on to bowel movements. You can have an amazing lifestyle impact. If somebody's incontinent and you make them continent, you give them the life back. In the world of colorectal surgery, we sort of divide things between abdominal surgery and anorectal conditions. Sort of the big three in the abdomen are colon cancers, colitis, and diverticulitis. I think there are a variety of other things that we manage, but those are kind of the big things. And those are all done in general when they get surgery through abdominal incisions, either great big abdominal incisions or little tiny laparoscopic incisions. Turning over to the other end of business, so to speak, there's all the anorectal conditions: hemorrhoids, abscesses, fissures, fistulas, fecal incontinence, disorders of defecation. And oftentimes patients come kind of muddled with that, or more simply stated, everything's a hemorrhoid. And then you find out that it isn't a hemorrhoid, it's something else, and you can help them. And then sort of in between those two things is actually the rectum. And the rectum is really a difficult and complicated place, and it's where colorectal surgeons really shine, because it's difficult to get down there from above, and it's difficult to get up there from below. And there's a number of conditions that are in particular to the anus and rectum that are not the same as anything else. You know, rectal cancer is very different than colon cancer. Anal cancer is different than rectal cancer. And they're all rare enough that you really need to have a frequency of management of that you're familiar with how to do it and what's changing in those areas. I'm very selfish. I love when people say thank you. You know, it's surgically, you really have a sense of self-satisfaction because, you know, I did something. I personally have almost no tolerance for surgeons that want to be heroes. I don't want to be anybody's hero, but it definitely, when you put your head on the pillow at the end of the day, it's very tangible that, you know, you did something good. Of course, the overriding principle of all medicine is supposed to be first, do no harm, and after that, leave your patient better than when you started. You know, and if I can do that service every day, then I've done my job. People frequently come to us feeling okay, and then you operate on them, and they have a period of time when they're not feeling so hot, but in the end, they feel better. So my philosophy of care is to hurt as little as possible and leave the patient better off than when I found them.